So hi everybody, thanks very much for joining. I'm Andy Dwyer and I am with the University of Colorado Cancer Center, the Colorado School of Public Health, and I noticed that we have several folks joining us live who are part of some of our specific initiatives related to colorectal cancer screening, as well as other prevention initiatives. So thank you so much for joining today, and as Taryn noted, this is going to be recorded real time for online viewing at another date. So if you have colleagues or other folks that would like to attend and to view these sessions, we will be saving those. And then Taryn, these are going to be on this the PNTC website. Is that correct?
Yes, that's correct.
Okay, great. All right, so and I've given a bit of update, and just as a quick reminder that this funding does come from the, we have funding for part of this work through the Colorado Cancer Coalition and their funding mechanism. So we're really grateful for the coalition for all their work, and as a reminder, their statewide symposium is coming up, and we'll be sharing some more information about that as well. So just a quick reminder that ultimately, and Taryn, can you see my slides?
Yes.
Okay.
The Alliance?
Yes, very good. And I think there is a chat that folks are interested in attending the advanced MI sessions, but not sure after they completed their survey, not sure if they would be notified if they would be able to take the class. Before we jump into this, Taryn, since I opened up that discussion, do you want to talk a little bit about that pre-test that's done for those who want to use the advanced sessions?
Yeah, so we just have a quick survey that we sent out through a test more than a survey that we sent out with Qualtrics, and it's only like 10 questions, but it is a pass-fail. So we allow people who get, I think, like 7 out of 10 or 8 out of 10 to do the to be a part of the MI sessions.
Okay,
and
great.
I think even if you fail, there's I would have to ask Erin and double check with her.
Okay.
I think we have a link that we send out, and you just have to kind of go through some online courses first, and then we'll if you send us like a certificate, I think, of completion, then we'll allow you to take the MI classes.
And I think, as I noted before, those sessions are specifically about ensuring that folks have really thought about their fundamentals of MI, because the work that we're going to be doing through those online sessions with Dr. Ritchie will really be about enhancing skills. So if you need a refresher, CCSP is doing a 101 session, and then there is that online module. So anyway, we should be good to go. Okay, great. And I would just ask that if you have any other questions, if you want to put those in the chat to the group or to Taryn directly, in case I don't see those, we want to make sure that Taryn, I'll take a stop every once in a while and just double check with you to see if there's anything else we need to cover.
Okay, that sounds good.
All right, sounds good. Everyone can still see the slide. This is the Alliance, Erin. We're good to go?
Yes.
Okay. Quick note about the PNCHW PDS Alliance. We are a 501c3. We did actually have this status that was put forth about a year ago. We've been largely a very grassroots organization over the last almost 5 to 7 years. We have about 300 to 400 folks who have expressed interest in following along with the work of the Alliance. So we're really excited about moving this work ahead, as our work is really centered around health disparities and really promoting the workforce for financially sustainable models for navigators, community health workers, promotor de salud, and other people who might work in other care coordination or health promotion type roles. So we're really excited about offering these sort of opportunities, and then we're really working on continuing to find better ways to make sure that these workforce, the care force, as I've heard affectionately called, continue to find viable means to stay funded and find fair and equitable wages. But through this, we also really want to talk about skill building. We are going to be talking today about colorectal cancer. We're going to talk about the basics, risk factors, protective factors, screening guidelines, and the roles and activities of how to navigate a patient into screening. So I'm thrilled to be talking about this, as my program specifically has been in the field for over a decade and is setting some trends in terms of national models and outcomes in terms of thinking about cancer prevention and control. So let's just talk about the basics. We are going to talk about the anatomy of the colon and the rectum, and talk a little bit about why, the why and how of colorectal cancer. So just as a quick reminder, when we're talking about endoscopy and colon and rectal, we are really actually speaking about the rectum and the colon. We're talking about the large bowel, the large intestine, and we're really thinking about this as an organ that has more of a cylindrical opening type tube type structure that will allow for different types of testing modalities. And so on the screen, you can see right now the rectum, the colon. You can actually see an endoscope, which might be a colonoscope or even a flexible sigmoidoscopy. And you can really look at how the bowel is formed. And I think it's really good to actually talk about this, because I think one of the biggest issues that navigators and health providers have with patients, even to begin, is just understanding what colon, rectal, colorectal, what that means in terms of screening and where we're talking about the body. And specifically, when we talk a little bit about why colorectal cancer and we talk about colon and we talked about rectal cancer, we're really talking about two somewhat different organs, but their biologies are similar enough. And of course, that they're attached, that when we talk about the two of them, we talk about them together. And a lot of times what we're interested in really examining right now is really thinking about precancerous growth, types of polyps, inflammation, hemorrhoids. These are the things that patients typically talk about development either as part of a normal sort of life experience, that inflammation, hemorrhoids might develop because of pressure in other instances. But as we either become, we're at increased risk because of a family or personal history or genetic condition that might put us at a predisposed risk, we can develop colorectal cancer. And then as time goes on, specifically polyp growth is something that happens as part of the normal aging process. And so you can see all of these sort of general cancerous growths, polyps, inflammation, hemorrhoids, the rectum, as well as the the sigmoid colon. These are the sort of things that we really want to be aware of. But one of the things I think that it's also telling in this slide is that you'll notice that polyps don't always bleed, cancerous growths sometimes bleed, and inflammation and hemorrhoids could bleed. So one of the things we have to really think about is management of education about colorectal cancer screening and signs and symptoms. So just as a quick note, that these are the things that we need to really think about related to the bowel and conditions attributed. So the real function of the GI tract, also known as the gastrointestinal tract or the GI tract, is to really help move the waste and to move once the nutrients are really exhausted and absorbed from our body, it's really trying to move that undigested and then the waste materials out. And so it's basically 26 feet long. So if you think about pulling out your intestine, the large intestine across, we're really talking about, that's a lot of a lot of feet in terms of, I'm thinking about myself being almost 5 feet 5 inches. So ultimately that's almost a little bit 4 to 5 times as tall as I am. So we're really talking about a large amount of tissue really compacted in a small area. And ultimately the bowel does incredible things for our body and keeps us exceptionally healthy. They are two different sections when we talk about colon and rectal. But as I mentioned before, a lot of folks really talk about the colon and the rectal together because of the biology being very similar, and understanding ultimately the anatomy and then the type of disease. We really think about the two of them together. So really it's the colon is the latter portion of the intestinal tract. It's sometimes called the large intestine. Like we've talked about, we know that water is absorbed and nutrients are absorbed through the colon, but often the bacteria in the colon is really what takes the breakdown and the like. And I think it's interesting to talk about bacteria and the like, because we talk about good bugs and bad bugs, but ultimately some of the bacteria, and part of the examination of looking at increased risk of colorectal cancer, especially maybe people who are particularly young, understand the microbiota and the bacteria is something that's coming into discussion right now to say, are there things that maybe influence that general kind of what's happening in the colon normally? Are there things that are being influenced, like certain types of food, processed food, antibiotics, or the like, that really might change how the bacteria looks and functions within the colon. And there's some debate right now about whether that could be one of the reasons for the incidence, especially in early age young folks getting colorectal cancer. So we're talking about the rectum, and ultimately we also talk about the rectum and colon and rectal together, as we saw in that general slide, the two of them together. With that rectum, you have the anus and the rectum being right in that period of that really, in the last part of that is about 8 to 10 inches. And it really holds in a lot of the stool. I think a lot of times that whole idea of like kind of a sphincter holding in type approach, that's really part of the rectal productivity and really what it does. But those muscles also then, of course, really work through helping extract stool and waste out of our larger colon. What I would say, though, is a lot of times when we're thinking about the colon and rectal areas, one of the things that we've noticed is that there is a little bit of a difference in terms of who's developing colorectal cancer. And right now, in especially the young, we know that about a third are actually, it's greater than that, but most of a number of the young folks who are developing colorectal cancer, a lot of it is really through the rectum. And this is an interesting question of biology and understanding if there is something very different between the colon and rectum, especially for young people who are being diagnosed. So just as a quick reminder, we saw that general tube, right? We saw that colon, we saw how long it is, we saw where it fits within the body, we saw the picture of the stomach, the liver, the large or small intestines, and then ultimately the large intestine encasing. But this picture is really kind of showing you exactly what's happening within the body and the colon itself. And really when we saw that picture of things that could be happening, there can be hemorrhoids that develop, there can be inflammation. But the things that for colorectal cancer we're really interested in is polyps. So not all colon and rectal cancer comes from polyps, but the majority of it does. And so that's why we really need to understand more about polyp growth. Essentially what you see here is really what we call the adenocarcinoma sequence. And if you look at basically cells starting to change on that inside of that tube, so we saw that outside, but if we look on the inside, we start to see these types of adenomas start to really develop over a period of time. And ultimately, you can see starting to see what they call hyperproliferation of cells. We start to see those cells starting to really crop up, having a little what they call dysplasia over a period of time. So those cells become a little erratic. They're not maybe working as well as they should be. And then we can see these develop of this growth happening, where you can even see some polyps that sit right on the surface, which are called sessile. But you'll also see this sort of interesting stalk-like approach. And those are ultimately called pedunculated polyps that really sit on the colon wall. So I think that's a fun word to say, is pedunculated. But then ultimately over a period of time, if these polyps are removed, you can start to see this abnormal cell growth that really can start to become invasive and turned as the cells become more sort of disorganized and freaky. You can ultimately see this sort of invasion not only into the general polyp area, but you can start to see that it starts to move into the wall of the intestine and then can spread throughout the body. So one of the things that I think is really interesting is, you know, if you think about it, a colonoscope, and so a tube and a colonoscopy type approach can come in here. So again, you know, you have really, if you're looking at this wall, on the top you have a wall, the bottom you have a wall. This cartoon just gives you an idea of how polyps can develop. But the fun thing is that you could ultimately have a colonoscopy or colonoscope coming through here with a nice light looking around. And then ultimately, if you see one of these sort of bad boys here, you can either take a bite out with a biopsy or forceps and look at that tissue, or you could even lasso these polyps and take them out. And so that gives an opportunity to look at what's going on in that cell, but it also gives an opportunity to completely remove the kind of tissue that would otherwise become that invasive cancer. So if you look at that adenocarcinoma right here, this pedunculated polyp that we see abnormal cells, and then it's really becoming cancer and it is cancerous, ultimately we could remove that maybe at the time where it's a precancerous polyp and never get to this spot. But even if we get an advanced type disease type situation or pedunculated polyp, we can oftentimes remove that tissue and completely ameliorate the issue altogether. So this is really the beauty of it. A lot of times, and let me just ask you guys, if you have a normal colonoscopy, what ultimately do people recommend for surveillance? And so let's have that written in the chat. how many years between a normal colonoscopy and your next colonoscopy? So let's say you have none of these things in here. Ultimately, how many years? And what are we getting? Oh, I'm seeing some responses. 10. That's exactly right. 10, 10, 10. Now, the reason that that is 10 years, interestingly enough, is that if you know, again, we called this whole thing an adenocarcinoma sequence, that it usually takes about 10 years for this whole sort of schematic that you would see this like hyperproliferation and these polyps to grow. It would take about 10 years for this from start to finish to get to being about a precancerous polyp or an adenomatous polyp here. So it's really exciting, I think, that we can see this ultimately that surveillance guideline of every 10 years completely in alignment with how long this takes to happen. And so when nothing's happening, and if I get a colonoscopy and the only thing that comes out is a colonoscope, so there's no polyps, there's no abnormal tissue, you can ultimately know that there's nothing going on. And so it will be 10 years before we'd actually see any sort of development. And that's why that 10-year interval happens. So thanks for those who played along, I appreciate it. And so why is this such a big deal? I think that it's really interesting that ultimately right now we know the incidence of colorectal cancer is really taking a good nosedive the way it should for people who are older than 50, those who are at average risk population. However, the bad news is that those who have increased incidence for those who are under age 50. And so like I talked at the beginning, we're still trying to figure out what that's about. But one of the things that I can tell you that's happening for good and for bad for both is ultimately it's a good thing. But I should say that right now that we know that incidence in colorectal cancer going down for those over 50 is largely to do with screening. We know that for people who are at increased risk of CRC and should be screened more regularly, so family history, signs and symptoms, genetic familial syndromes, a lot of those folks who should be screened well before 50 are not doing it at the rate they should be. And so ultimately, we know incidence for these folks is actually up. And colorectal cancer is growing in the younger population. It's now the second, one of the second or leading causes of death right now, and incidence rates are going up for young women. And it's really actually quite scary. So we're taking a lot of dedicated time at the Cancer Center, as well as with a lot of our efforts to understand that family risk. So you know that you have to be screened earlier, or even knowing ultimately what's going on with signs and symptoms. So this is something we should take seriously. Cancer is the leading cause of death in Colorado. Lung cancer is the leading cancer killer, and colorectal cancer is the second leading. So the good thing about colorectal cancer, though, is, again, we have huge opportunities for prevention. So ultimately, we also know that all races that we're at a 32.5, so a 32.5 people per 100,000 will develop the disease. But if you look at the number of people who will actually die from colorectal cancer in Colorado, that's almost 700 people this year. And what's interesting is that if you look at the white, Hispanic, white, so if you look at Hispanic populations and African American population, we know that the incidence is actually higher than the non-Hispanic folks and the non-African American folks. However, I will say I think that actually right now at this time, those who are of Asian descent actually have lower rates even than white non-Hispanics. But I think that it's something we should take very seriously about looking at some good opportunities for health outreach, especially to populations that we're reaching who might have increased incidence. So you have about a 1 in 25 chance of getting colorectal cancer. If you're a man, you have about a 1 in 21 chance of getting colorectal cancer. We know that we have ultimately over 17,000 CRC survivors. And what I would say is that ultimately we also know that if colorectal cancer is found in early stages, it's about 90% curable. So that's a huge part about even prevention and early detection, is that we really need to identify those risks. And you have to, of course, know that family history. So again, just talking further about that distribution, we know males have colorectal cancer at a slightly higher rate, but for all intensive purposes, it's about equal. But again, we see that especially within the Hispanic and African American population, we ultimately see that the increased incidence. And so anyway, if you look at annual rates of colon cancer death, again, we're seeing that steadily come down. And so hopefully that will continue as our screening rates continue to rise. But if you look at Colorado right now, a percentage of adults 50 to 75 who report being up to date based on the BRFIS data, we're still right in the middle of the pack. We hope to be at 80% by 2018, but we've got some work to do. So I just want to say that we know, especially in the FQHC systems, that sometimes screening rates can be in the 20s to 30s to 40s, but we're actually seeing that increase in some of the groups to almost 50%. But as a state, we could do better. I mean, there's no reason that California should be beating us, just saying. Okay, so next, I just want to also talk a little bit about what it means in terms of screening, early detection, and then ultimately the burden within the state. So Taryn, just to double check, you can see my state map, correct?
Yes, I can see it.
Okay, great. So ultimately what we're seeing based on the data that's shared from our state health department is we know that even within our state, not all things are equal. There has actually been an updated map in the last couple of days that I'm going to go ahead and share at another time, and there have been some changes, but ultimately what we do know, and some of this is still very much the same, is in the eastern plains of Colorado, especially in northeast Colorado, we see some incidents being exceptionally high, or in terms of looking at late stage incidents. We also know that some of the counties that have more etching are the sometimes what we're considering poorer counties based on the state average. So if you look at some of these darker spots, especially over in Region 19, so that Grand Junction area to northeast to southeast Colorado, we see some of the more impoverished areas have later stage incidents, lower screening rates, but there are some parts of the state, especially in the Metro Front Range and other areas that are doing particularly well in terms of screening rates. So the screening rates are the bubbles, but then ultimately the darker colors are the later stage incidents. And then ultimately that etching shows that sociodemographic sort of, and it particularly relates to poverty levels. So this is something that I think we should all be thoughtful about. I think if you're in the middle of the pack, be careful, you can slide down, but you've got some great opportunity. For those who are in regions where you're looking at late stage incidents and lower screening rates, we can all spread the message about different types of screening modalities. And if you're at the high area of high screening, lower incidence, congratulations, keep it up. And we'll try to share the lessons learned from those opportunities for CCSP and other programs. So just as a quick reminder too, that I just want to remind everyone that the state health department, CDC, and others have fantastic information about screening rates for our state. They can share a little bit of information about testing usage, about screening rates. Use this information widely. We try to share this through the Alliance and other types of opportunities, but really familiarize yourself with what's going on within the state. So we won't go into this in great depth because I'm running a little bit behind, but just as a reminder that ultimately we are seeing increased screening rates overall, decreasing within the older population, increasing in younger folks. We know African American and Latinos, again, are at increased risk of developing the disease, and not all of our state is equal. So just as a really quick reminder that we just really need to make sure that we think about who we're working with and where to go. And again, just as a quick reminder, in showing the incidence of disease, this right, ultimately, this graph to the right really shows you with men and women, even in young folks, we're starting to still ultimately see the colorectal cancer diagnosis still being higher in the 20 to 49-year-olds. And then ultimately, even at the University of Colorado, we're doing a lot of work in this area to understand causation and etiology. And this is something that I think we're going to have to continue to keep on our radar. But one of the things that's interesting is that what we're seeing, and there was a change in the American Cancer Society guidelines, is we actually are seeing that ultimately we are seeing that colorectal cancer incidence is now the same in 45-year-olds as it was in 50-year-olds about 15 years ago. So this is really interesting fodder for the ACS and others doing interesting modeling and calculations. But the bottom line, and one of the most compelling arguments, is about 15, 20 years ago, when USPSTF set the guideline and really honed in on 50, we're seeing those same rates again, let me say it again, for 45-year-olds as we did for 50-year-olds 15 years ago. So that's really something that's really quite disturbing and interesting, but we have a huge potential to go ahead and get that word out. So again, this specifically shows a little bit of like who's getting screened and adherent to screening guidelines. So just as a quick reminder, the populations, we're not quite where we need to be, but we do have some, we have some groups that are doing a little bit better than others, but those 50s and 40s need to be closer to 80 to 90% to really look at a reduction in mortality. So we talked about a bit about the difference between the colon and the rectum. And ultimately, we've gone through a lot of the word that we really need to consider. So I want to just go back to that whole idea is that colorectal cancer, there's nothing I can do about getting colorectal cancer. That is not true. And we do know, as noted, that colorectal cancer is mostly preventable by moving precancerous polyps, exercise, aspirin, folic acid, non-smoking, eating diets high in fruit and vegetables, reduce processed meat intake, which is something I'd like to talk about as well, and quality meats, and consuming rather quality meats is something that we can do. About 2 or 3 years ago, we actually did note that ultimately the foods that are often grilled or have a lot of the fluorocarbons related, those sort of meats can put us really at a higher risk of developing colorectal cancer, so smoked, grilled, and the like. But we also know that foods like hot dogs, processed meats, and the like can really increase our risk of getting colorectal cancer. So if you're consuming meat in moderation, but let's make sure that it's good meat, quality meat, and that we're really thinking about also the rest of our plate, really having a lot of fruits and vegetables as well. So let's move on to the next myth, is that colorectal cancer is usually fatal. That is not true. When detected early, there is a lot of room for curability. 91% of patients with localized disease, so that hasn't spread into the bowel wall or hasn't gone to other parts, have curability, like I noted. But only 37% of patients are diagnosed currently at early stage. So what I just want to remind people is that in addition to thinking about that family history and the like, we also have to think about that if you're having signs and symptoms of colorectal cancer, it's not always hemorrhoids. It's not always inflammation. It's not just something that you ate. It's not that you just have a bad stomach. It really needs to really ultimately be checked out. So blood in the stool, change in bowel habits, unexplained weight loss of 10 or more pounds. These are the kind of things that we need to take seriously. And as navigators and community health workers, we need to stress this to our patients. This one is also one of my favorite, is that women don't need to worry about this disease because only men get it. So the reality is, when we saw that graphic, even though there's a slight increase in certain groups with men and women, so in certain age groups, women are more likely, a little less likely, and the like, but it evens out. When you put everything together, men and women are both equally have the same odds to basically of getting colorectal cancer. So that's a lot of times we call it the equal opportunity killer. So there is nothing that really should skew more men getting screened, women getting screened. It really needs to be same messages to patients about the importance of getting screened. So an estimated 148,000 were diagnosed with colorectal cancer in the US in 2002. So ultimately, these grades that we know that have actually died, or have actually, and that should have been 2012, but ultimately that we know that, so we know even with these rates that an estimated 56,000, so more than half of that was women. So in any given year, you might see a little bit of difference, but really for all intents and purposes, it's about the same. You need to have colorectal cancer screening only if you're having symptoms. So let me ask that. Do you only get screened for colorectal cancer if you have symptoms? Yes or no? False. Very nice, Erica. No, 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 no. Okay, fantastic. That's right. So ultimately, one of the biggest causes of signs of colorectal cancer is nothing. So it's often silent. So ultimately, we want to make sure that we are having those routine screenings. And so ultimately, people who are at increased risk might be able to start screening before age 45 or 50. Those who are at average risk populations need to start at screening at age 50 regardless. So you have to pay attention to those guidelines based on elevated risk, or average risk population, or if you have a genetic or familial syndrome, you might need to even be starting screening as young as in your late teens and early 20s. So the polyp can grow and it doesn't necessarily bleed. Some of the veins, people in their 20s and 30s are oftentimes not always having symptoms, but ultimately have a high risk or an elevated risk because a family member a direct family member might have had colorectal cancer or advanced adenomatous polyps. Okay, so let's go ahead and then ask the next question. Myth, it is wrong, but colorectal cancer screening tests are not covered under most health plans. So write in the chat anything that you think that is contrary that makes that a myth. Why, what do you know about colorectal cancer screening now that you would say has provided huge opportunity? And I'm going to say it rhymes with Schmedicaid Schmishmansion. So that's one of them, but anything else that you want to say about insurance, go ahead and write that in the chat for me. So the myth is colorectal cancer tests are not covered under most health plans. So anybody who wants to write about that, feel free. Medicare and Medicaid and most private insurances do cost. And so that's right. Screening should be covered by insurance. So there are some exceptions to the rule, but ultimately most medical plans based on the ACA provision for screening and early detection, ultimately we know that people who are 50 or older, who are average risk, as well as those who have an established high risk or elevated risk, are covered under the preventive screenable strategy as well. So, yep, I think that is a really good point. Some people might have a deductible. There still are deductibles, there's still copays on occasion, but most plans at this time should cover the majority, if not all, of the preventive screening, but it is something to always ask and double check for patients. But most insurance plans do cover. So colorectal cancer is one of the only that can be prevented. There's new tests that detect cellular changes and blood, which can mean polyp development or cancer. So early detection is the most important way to prevent colorectal cancer. I think we all know this. And we also know that anyone can develop colorectal cancer. Cancer has no prejudice. It is found in all racial groups. Men and women have equal chance of developing CRC, but we also do know that there are certain groups who actually get colorectal cancer a little more frequently than others. So we have to pay attention to those signs and statistics, and we really have to think about ultimately how we manage those messages about colorectal cancer to our specific populations. So we've talked a little bit about the development of over time, and we talked a little bit about the primary prevention, about what not to eat. But there's also things like diet and exercise. Now also specifically thinking that there might be environmental factors. There's currently a study that's being conducted from the American Cancer Society to also even look if there's folks that might have different types of environmental exposures in there based on their professions that might actually put people at increased risk. So this environmental piece is really going to be coming into play, especially I think as we start to examine etiology for early age disease. And then of course, knowing your family history is pivotal. One of the things that we've done throughout the state of Colorado and some of the leadership with the CCPD programming, as well as other types of programs and currently clinically, genetics and familial syndrome type work and really identifying who's at risk is something that's happening a little more routinely. We know things like Lynch syndrome, as well as other factors, might put people at an elevated risk for colorectal cancer, but it doesn't mean that only people with colorectal cancer have Lynch. So if in a family, we see people have ovarian cancers or uterine cancers and other types of cancers, there might be mutations that lead to colorectal cancer, even though they didn't manifest as colorectal cancer in an individual. So it's really important, and there's a lot more energy and time input into understanding people's risk in genetic and familial linkages as well. But really the biggest risk factor for developing colorectal cancer is still age. And again, that's why we really have looked and taking into consideration those guidelines that starting at 50 and now at the ACS says at 45. So what makes a factor a risk for cancer is often how long you've had it, and how strong. So these are the things that we really need to think about if you look at this exhaustive list, is ultimately that age group, history of colon or polyps, colorectal cancer or rectal cancer, looking at those hereditary risk, and ultimately that's really thinking about having something like a genetic syndrome. The difference with a family history is if someone's had colorectal cancer or had adenomatous polyps, that might be a little bit different than ultimately having a genetic syndrome, but these two things are very important. We'll talk about that in a little. We talked about the ethnicity, growing older, history of having those polyps. But the other thing that we also know is that ultimately tobacco use is now linked ultimately to colorectal cancer development as well. We've known, of course, for breast and for lung, but about 5 years ago, they actually made a direct correlation around tobacco use, and then ultimately the processed meats, fruits, and vegetables. And there's even an interesting hormonal connection between diabetes and the like. So ultimately, when we really think about all of this happening, if you have a lot of these factors usually coming in together, your chances are somewhat more elevated. So it's really helpful to kind of understand that risk of primary prevention, being more active, not being sedentary, eating quality fruits and vegetables, more fruits and vegetables and fiber than meat. If you do have meat, make sure it's good meat. These are the kind of things that we need to consider. That family history, the holidays are coming up. Have a good old talk with everybody in your family about like what's going on with their health. If you know that someone's had a diagnosis or something that seems out of the ordinary for their health, have a conversation with them about what that might mean for you and for them and the rest of your family. So ultimately, we talked about that silence, that no signs, no symptoms. So ultimately, again, the biggest cause, and ultimately most people don't typically notice, they typically have colorectal cancer. So I talked a little bit on the fly about the symptoms. So I think this is something like we talked a bit, is there are folks oftentimes that can say, well, you know, I have normal gas, or I was just, you know, thought I always just had like an irritable bowel or a bad tummy, or, you know, bad tummies run in my family and the like. I think we're getting to the point now that we're seeing such that interesting increased rates in folks who are young, people who haven't been screened, that we have to ultimately pay good attention to thinking about those signs and symptoms. And I think one of the things, there was a study done here at the university that was published and presented at GI ASCO and ASCO actually over the summer. And we actually had realized that most patients, and particularly young patients, were ultimately 294 days from the time they presented with symptoms to the time that they were actually diagnosed with colorectal cancer. 294 days. So one of the things I think is there's a certain amount of patient responsibility. We've got to talk to people and the like, but we also know that within the medical community, within primary care, within the health promotion work that we're doing, we got to remind people that ultimately these sort of changes are things that can't just be put to the side. This could be a diagnostic issue. So changing those bowel habits, particularly narrowing of stools, oftentimes what people consider to be pencil-like stools, those sort of components, something that's changing drastically, gas pain, constipation or diarrhea, weight loss without trying, 10 or more pounds unexplained. That's never happened to me, by the way, so I would be alarmed. Weakness, iron deficiency, and bleeding. Those are the kind of things that we actually typically hear about for signs and symptoms. This might be truly something that's not that serious. It can be an IBD, it can be an IBS, but it also might be something, and not just say that IBD isn't important, because it is, because a lot of folks who have IBD or Crohn's disease can ultimately end up having an increased risk, but they can be diagnosed if this is it. It doesn't always mean colon or rectal cancer, but it could mean something else more serious. It could be polyps, it could just be a bleeding ulcer or something of that nature, but we have to have those conversations with our medical teams and our patients about the importance of really recognizing doing something about this. So we talked a little bit about the benign, we talked about the precancer. Size does matter. Ultimately, the larger the adenoma, the more serious we should take this. Ultimately, the histology, so knowing if we have an advanced disease type situation is good as well. We'll get into probably another day of knowing if you're so interested in these sort of things. We can talk a little bit more about even advanced adenomas, but ultimately we have to really think about size and the like, as well as the histology. But we also know for production, ultimately, getting 30 minutes or more of physical activity, and really making your heart pump is some of the things that we could do, as well as really increasing that vitamin D and high fiber type diet as well. So I think we've actually talked most about these, but I think what's interesting too is for menopausal women, we do know that in some situations, replacement therapy and hormone replacement therapy can increase sometimes breast cancer risk, but it's shown to be protective of colorectal cancer. And the other thing I want to say is that there's also interesting studies right now that show that low dose aspirin can particularly help people who have polyps develop. So a low dose aspirin daily is something that's often recommended for people who are commonly known as polyp growers. So this is something to take into consideration as well. As navigators, community health workers, promotores, we might not explicitly be talking to the patients about recommendations of those specific medications, but in the literature it does talk about ultimately not only being good for preventing heart problems, but we know that people who have a history of developing polyps, and if they take a low dose aspirin, it really reduces that inflammation and we might not see the development the same way. So we know ultimately, and we've talked a lot about now the causation, we've talked about ultimately what's happening in Colorado as well as the nation around development of colorectal cancer. We know that it's preventable, we've talked about the polyps and the like, but the ultimate question is ultimately what can we do about it? So I want to take a just quick visit to the USPSTF guidelines recommendation. So the USPSTF stands for the United States Preventative Services Task Force. And the USPSTF is basically a group that particularly talks about our guidelines as it relates to the average risk population for a number of chronic conditions and preventable diseases. So at current time, the USPSTF is recommending that people use FIT test, fecal occult blood test, FIT, as well as sigmoidoscopy, colonoscopy, as well as some of the stool DNA recommendations as well. So this one actually is a little outdated, my apologies. But ultimately we know that right now that people are using stool DNA, FIT FOBT, as well as FOBT, colonoscopy as the A type guidelines. And ultimately, we know that the recommendation that they have stopped is that after 75 years old, they don't necessarily recommend screening for everyone, only if folks are healthy enough. So ultimately, this is one of the recommendations that's put forth, colorectal cancer, as well as many of the other recommendations, that if something has an A grade rating, then from a preventable, or an A or B rating, then it is covered by most Medicaid, Medicare, private insurance typically. And most guidelines, or most insurance groups actually utilize the USPSTF recommendations. So we're going to talk about that ACS guideline and a little bit of the rub. But what I would say is right now there are a lot of screening modalities. So for the average risk population, using any of the guideline approved screening tests are something that are okay. But for those high risk population, colonoscopy is the only thing that should be really considered at this time. So interesting side note, right now the USPSTF has put out a call for an RFA and they are currently reviewing their guidelines, so we might see some changes as well. So as I talked about before, and we'll just do a quick reminder, is that ultimately the American Cancer Society about a year plus ago have changed their recommendations to 45 years old, that ultimately noting that they saw from their modeling data and the like that there was good evidence to suggest that we should start screening the average risk population. So people who have no signs and symptoms, people who aren't at elevated risk because of family history or genetic syndrome should start screening at age 45 years old. So what I would say is that some states have adopted this guideline. In Colorado, we are still utilizing USPSTF for most of our guidelines, but there's currently initiative within the Colorado Cancer Coalition, as well as several of the members through ACS CAN and the like, to look at being able to offer the preference for providers and patients to start screening at 45 years old versus at 50. We'll keep everyone updated about that, and there has been some movement in states like Kentucky and Maine to move this ahead for at least some of their insured group, but we're going to be really looking at moving this ahead in Colorado over the next couple of years. So ultimately, we've talked about this. Average risk based on USPSTF is 50. ACS, it's 45. If you have a family history of colon symptoms or polyps, you need to start talking to your doctor earlier. So recommended screening methods. This is what we talked about and was on that guideline. Ultimately, A recommendations currently exist for USPSTF for the colonoscopy every 10 years on an annual basis, FIT and FOBT, stool DNA every 3 to 5 years, virtual colonoscopy is on that list, and a sigmoidoscopy every 5 years, coupled with a high sensitivity FOBT or FIT kit is also recommended. So what I just want to remind everybody though is that if you are thinking about an annual FIT or FOBT program, notice it says annual. Right now there is no evidence to say if it's done once that it really does anything in terms of incidence or reduction mortality. So the one and done is really pretty much the colonoscopy, but that's still every 10 years if everything's normal. But that more sort of not having to do it every year is really connected to colonoscopy and now somewhat to the stool DNA, but not all insurance plans at this time are covering stool DNA. And so we'll hopefully see more movement about that going forward. But just as a quick reminder, if you're choosing a FIT and FOBT program, which are still great modalities, making sure that you have infrastructure and that you really think about how you're going to message to your patients and provide that input about adherence on an annual basis is something to really consider. So ultimately the colonoscopy, like we talked about when I talked about that looping and that lassoing and removing, that is really the opportunity for people to look into the colon, see the colon, as well as removing tissues as they can do that. So that is huge because you can, of course, as we talked about, remove the polyp. And one of the things that we heard from ultimately from folks is that ultimately people really like, particularly men, have talked about the need for colonoscopy, that if it's average risk, you only get it done every 10 years. And so that's the real benefit there. One of the things that we do know right now is that, and that we do know that people who have increased risk are ultimately sometimes provided colonoscopy every 1 to 5 years as well. So this is a picture, people lay on their side. You actually see the doc who has a colonoscope. They're looking in as they advance this tube. So there's ultimately a camera that shows what's going on. If they're when they're inside, when they have the scope in there, they can actually move those clamps or move those lassos in to go ahead and utilize those and pull out the material to use to go ahead and prevent real time, but also look at what kind of tissue's been growing. So this is something that's definitely invasive procedure, requires a lot of good background and information about how to adhere, which is really one of the things we want to move into currently. So ultimately, when we talk about colonoscopy, we also think about that idea and need for making sure that we have great and adequate preparation. So all colonoscopies will require that someone has a clean bowel, that they're ready to go, that the doc and the team can ultimately visualize what's going on in the colon. And so we really have to think about not just the one time of that appointment the day of, but it's really thinking about a process as much as a week ahead of time for the shopping of thinking about the reminder calls, thinking about what to advise people when they're shopping through those calls about clear liquids. If people are on medications like blood thinners, Coumadin, anything of that nature, they need to really talk to your healthcare team about maybe reducing that altogether or having some sort of plan so that there's not a bleed if there happens to be any sort of perforation, which does happen rarely, but it does happen. And then ultimately making sure that people are really thinking about how they're going to ensure they have clear liquids, eating plenty of light food ahead of time, avoiding even a couple days ahead of time, drinking plenty of water, but avoiding big types of heavy meals that might make it even harder for the day or two to prep. And then, of course, the day before, wanting to make sure that people are only using clear liquids and staying hydrated, but ultimately they will be using the bowel preparation material that will also then cause that cleanse to ultimately remove all of the extract so that there's mucus, any stool type residual that's there, that we can move that away. So again, when they're in there with that scope, they have the best chance to see what's going on. So after the colonoscopy, we know that people are ultimately, they will be sedated during that procedure. We know someone needs to come with them to drive them home. Even if people don't have someone, we know a lot of times and most times that people aren't allowed to basically take an Uber or taxi home. They need to have someone accompany them because we don't want them to be in a vulnerable position because they will be still having that lack maybe a little bit of grogginess because of the sedation and the like. And that there might still be that uncomfortable letting of gas and fullness in the abdomen. So those are the kind of things that we also need to consider. So that planning is going to be essential, but ultimately even knowing that the normals, like what's going on after the colonoscopy, also making sure people understand what's normal and then ultimately what is abnormal. So excessive bleeding, feeling super sick or having any sort of thing like that we need to really discern for folks that as well. And then we also need to remind patients, and this is something that I think with our program we've noticed, is that not all patients are clear about what their next steps are. The provider might have given some inclination about what happened. So of course, that if polyps removed or an adenoma or there were tissue removed, they might share this information and say they're waiting for pathology. But one of the things that was interesting out of the CCSP program is ultimately we realized that a lot of folks weren't clear about the next steps in their health. So one of the things that we've really instituted is making sure that once the doctor and the GI team, as well as maybe perhaps the primary care doc have checked in, a navigator can be a really good person to check to make sure that the person's received their results and understand about next steps. So again, that whole idea of, role appropriateness, most of the time with community health work and navigation, if someone's working in the lay capacity, we don't talk about giving people direct medical information, but we can be a really good support in terms of reminding people, just giving people a follow-up to make sure they're clear about their recommendations and they're sure about their next steps. So this is something through our program that we noticed when we did a patient satisfaction survey, that only 70% of patients were clear about what they were supposed to be doing next after having their colonoscopy and having been navigated through our program. So that's something that we instituted, not just that reminder call 2 to 3 days for the prep and the day before the actual exam, but ultimately that follow-up call so people are clear about the next steps in terms of thinking about when they should have their next exam. The FIT and then the FOBT, specifically for the average risk population, and I want to just ask this to everybody now, just to see if you guys are still paying attention. Ultimately, for FIT and FOBT test, should you utilize this for someone who has a genetic or familial history? Should you use FIT and FOBT testing? Let's see who's still awake. Anybody? No. Julie, Laura, Ashley, oh my gosh, here's my stars. You guys are awake. Connie, okay, great. Lisa, great, awesome. So the answer is no. And I think this is something that's really important to remember. If someone talks about having signs or symptoms, if they have a genetic or familial syndrome, if they've had colon cancer previously, if they've had adenomatous polyps recently, those folks do not get FIT and FOBT. They actually would go straight to that colonoscopy. So we've talked about that high-risk population. The FIT and FOBT is a great tool, showing over reduction of mortality over 30 to 40%. If used regularly, I mean, we can really see some good outcomes. But ultimately, it's only for the average risk population. It is inexpensive in terms of the test and utilizing it. The FIT, so fecal occult blood test is what it stands for. Fecal immunochemical testing. They're somewhat similar science, the FIT and FOBT. The thing is, both of them have to be done annually. They're at-home tests. They're inexpensive. But if you are thinking about implementing a FIT or FOBT, where the cost comes in as a program is having those reminder systems. So are you going to mail it? Are you going to give those person a time? How are you going to track it? Who's going to follow up the next year? These are the kinds of things that really kind of are expensive. So it's really critical that you're clear with the patient about what the next steps is. And if you are going to put in a FIT or FOBT program, you have to have a plan for at least 3 to 5 years. Okay, let's talk about stool DNA. How many people have seen the Cologuard commercial? Yes, if you've seen Cologuard. Yes, if you've seen Cologuard. All right, so the Cologuard with Exact Sciences is really an interesting test. And I got to tell you, I'm a huge fan, except if you have to pay out of pocket. Ultimately, the Cologuard test, where the FIT and FOBT test really look for blood, human hemoglobin. What the stool DNA test does is it's part FIT, so it looks for blood and it looks for that hemoglobin, human specific, but they're also able to look for cellular DNA changes that aren't necessarily blood. So if anytime we have a cell, we will definitely have slough off of different types of tissue and DNA changes. So if there is a DNA change that is not blood, but it might be an abnormal type cell, this will pick it up. Right now, we know that it detects over 90% of the colorectal cancer based on the trials. It's conducted every 3 to 5 years, so different than every year. Covered by Medicare for sure. So Medicare took a strong move to cover stool DNA. And I think Medicaid, I'm not quite sure. I think on occasion, most Medicaid plans are getting ready or covering it, and the same is true with most private insurance. It costs less than a colonoscopy, so we do know that ultimately $500 to $600 if somebody pays out of pocket. I think that price has even been moving down more for out of pocket, but we do know more insurance plans are ultimately covering the stool DNA. I got to tell you, I'm a huge fan of this test. I think the idea, and I think that the technology is only going to get better if we can just make sure every insurance group pays for it, and it also doesn't require that every year type situation. So stool DNA, it's got an A grade. Fit and FOBT got an A grade. Both of them have to have a program to substantiate that they happen every 1 to 3 to 5 years. You have to have that plan to make sure that it happens. I get calls on occasion from people who say things to me, you know, I've been to X health fair and it's, I've had 3 positive fit and FOBTs in a row every year. What should I do? So I think these are the things that we have to also give some really good advice to our patients about ultimately what they're going to encounter in the wild. So if your patient is calling about going to a specific health fair, if you are manning health fairs, if you're at the booth or the like, just make sure that people know if they have currently blood and the like, they need to have a colonoscopy. If they have had a FIT or FOBT that's shown positive, that goes to colonoscopy. Do not get 3 years in a row of bloody FIT and FOBTs and then still have another one. That's really a bad move. So these are the kind of things that we really need to tell people and keep on the radar. And then ultimately the virtual colonoscopy, and it's interesting because I think the radiology community has really found, they did of course find that ultimately using CT topography is great in terms of being able to visualize what's going on in the colon. But guess what happens if you have a positive, if they see something in the CT it should be CT exam, virtual colonoscopy. Guess what happens? Anybody? Write it in the chat. Colonoscopy, colonoscopy, colonoscopy. That's right. So ultimately, if anything comes from that situation, and that still requires bowel preparation, it still requires even insufflation and air in the colon, that ultimately that a polyp is found, or if there's a mass that they see, you ultimately have to go in for a colonoscopy. So these are the kind of things that we have to take into consideration as well for folks. All of these great tests for average risk folks out the gate are good, but if there's positives, you have got to think about capacity for colonoscopy. So again, Medicare does a great job of really actually covering a lot of the exams. I do know that right now there's the copay and co-assurance that basically we're trying to work through Congress at the national level. And I think one of the best things to probably help put this in perspective and what the problem is someone said, basically if you go in for a preventive screening colonoscopy, it should come out, you should come out paying the same price that you thought you would have. So what's interesting is a lot of times if adenomas are removed or if something of that nature happens, they're calling those colonoscopies diagnostic, and oftentimes people are having to pay out of pocket and use their co-insurance and the like. This is something that we have to be very vigilant about. So I know that there are groups that have worked with their coding offices to help figure this out, but right now there's even a law that they're trying to put into place, and ACS Can, Fight Colorectal Cancer, and many other folks are really thinking about how to get past this, what they're calling loophole. So that way we don't have these kind of out-of-pocket expenses, especially as people who are on fixed incomes. Medicaid currently doing a great job in terms of covering FIT, colonoscopy, and then typically no pay as well for those who are not symptomatic, and then somewhat of a copay for those who have diagnostic. Just as a quick in the chat, if we can have anybody share with us right now, anyone seeing anything around stool DNA and Medicaid? Anybody want to give any update? And if you can write that in the chat, I'm going to keep buzzing along. but I've heard some mixed situations about Medicaid and stool DNA. So if you have anything to share, that would be fantastic. So ultimately, some of the things that still are really challenges, the exchange plans, ACA, we know that diagnostic really even still covers some out-of-pocket. We know that asymptomatic, we have to be calling that screening. We know that if a polyp is found in some of the Medicare situations, this could be considered, with that loophole bill, we could see some issues. And no polyp found, we're screening still. And then family history, you absolutely have to start screening before the age of 50. And there are different surveillance guidelines, but those most of the time should be covered by insurers to make sure that people have the appropriate type of screening. So just as a quick reminder, moving ahead, that you have to document if someone under the age of 45 or 50, 50 USPSTF, 45 for ACS guidelines, really what their reason and rationale is. So we talked a little bit about coding variations. Some people have caps, some people still have copays or deductibles, Medicare charges for polyp removal, and some people are, really having issues with that diagnostic. It's just really good, I think, that if you work in a medical setting, you have some good conversations with your billing people, your medical directors, and talk about the challenges that folks are seeing. And the one thing I just want to say right now is that the best screening test is the one that gets done and gets done well. So it's good if you have a FIT or FOBT one time, but if you don't have it 3 to 5 years in a row, it's same as not doing it well at all the first time. If you go in for that colonoscopy and you're now bowel prepped, it's not going to go well. First off, you're probably not going to get the appointment. Second off, if you do, you can't be assured that the provider saw everything that they absolutely should. These are the things that we absolutely must consider. The best test is the one that gets done well and for the right person. So what I want to talk a little bit right now is also going into that more of that familial and hereditary conditions that we talked about. So I threw some terms around earlier, but we ultimately know that Lynch syndrome is accountable for about 3 to 5% of people who have colorectal cancer. Familial adenomyopolyposis, which is standing for FAP, is still less than 1% of CRC, and then familial linkages. And so basically having someone who might not have tested positive for a gene mutation or anything of that nature, but then does ultimately have a connection for the family is up to 20 to 25% of those folks. So ultimately, when you look at all of this together, so that 5% plus 5 or 20 plus 1, you're in about 25, 30% of this group that if even from the familial and hereditary risk, we could ultimately avoid colorectal cancer if people follow the same guidelines or the correct guidelines around increased risk and getting screened well before 45 or 50 based on their risk. So this is something, but the other thing we have to do is identify these folks. So we know that right now, even only about 1% of those who have Lynch syndrome have been identified based on some of the projections that have been put forward. So I know some of the clinic partners on the phone today even have started implementing a population-based familial and genetic history screening within the average or within the normal population that you're seeing. So these are the ways that we're going to really get to that. But ultimately, we have to identify these folks and make sure that they have the type of screening that they need well before the age of 50. So interestingly, we know that Lynch syndrome is really something that starts in terms of the general population. The overall risk of developing colorectal cancer if you have Lynch syndrome could be as high as 80%. So even though we know that only 3 to 5% of the population who have colorectal cancer are Lynch attributed, those folks really have an increased risk. So this is huge. We know that ultimately they're polyp growers, they grow fast and they turn to carcinoma quickly. And they ultimately will be in risk of additional cancers such as the uterine and the leg that I mentioned previously. So we ultimately know that at this point we really, really need to think about these Lynchies and identifying them much earlier so that we can start screening earlier. In terms of the hereditary HNPCC, the hereditary non-polyposis colorectal cancer, it's one of the more common forms, but ultimately we see an early onset. So if you look at those people who have this sort of situation, they have hereditary prone disorders. Typically there are situations where you can help identify them. We have to be really assertive about their diet. about the removal of polyps and thinking about really their recommendation. And here's why. Wait for it. Boom. Hundreds of thousands of colonic adenomas. So ultimately, when you see these sort of people who are HNPC C, they can have that consideration. But if you look at even those who have FAP type situations, these are the sort of folks that we really understand that they have a 100% chance of colon cancer if they are not monitored. And a lot of these folks will end up having a lot of their bowel and colon removed because of this situation. So some of these folks actually get started if they're found to have FAP through genetic testing or through this ultimate situation where you can see there's polyp development. You see people getting screened very young. So these are the type of folks that if we know something is going on, that we can really help save their lives by making good recommendations. So there's a couple of the other groups that we've talked about it, attenuated FAP, which is ultimately looking at certain types of lesions and the like that we might see later onset that you'll hear about, as well as looking at some of those who have young kids who have genetic polyposis type situations and syndromes. These ones aren't common, but the situation is ultimately that we know that ultimately if these folks are diagnosed with this sort of disease, that their chances of developing colorectal cancer are exceptionally high. So again, if you hear of these sort of folks, if you are identifying Lynch syndromes, these are things that are taking into good consideration and being the person who can connect with your healthcare team about understanding the surveillance, sharing this information, being someone who's an advocate for sharing family health information so that people can understand when to start screening. These are things that must be considered. So I'm just going to talk a little bit about the diagnosis and treatment of colorectal cancer. So we ultimately know that most of the patients who are diagnosed with stage 1 disease, there's not as many of them as there should be, that ultimately early detection and prevention is what we're aiming for. But a lot of times, because folks aren't either getting screened on time, they're not paying attention to the signs and symptoms, a lot of times they are diagnosed later with disease. So this is something that we really need to pay special attention to. So most in treatment involves at least surgical removal and chemotherapy in terms of an early diagnosis. And then contrary to popular belief, few CRC patients have permanent colostomies. So colostomy, as many of you know, of course, is that ultimately part of the colon is removed or all of it is permanently removed, and a bag is actually external that's placed where the fecal matter and debris will go from the actual consumption. So where our bowel once was is removed because of the cancer situation. So some people will have temporary colostomies. That's becoming more routine as well. So these are the things that we can ultimately know. But what I will say about this is that we also know for a lot of folks that right now that all patients aren't completely clear about what will happen if they do go in for surgery and if a colostomy is needed. So we've heard stories of patients not knowing that this is going to happen and being devastated to learn that they've lost their colon and that they will now have a bag. So I just want to remind folks that as being navigators in a lot of times primary prevention, or excuse me, in primary care centers or in the community, that if someone is diagnosed, they're going to really need someone to help them maybe make a connection at a cancer center with a social worker or a navigator in that arena, being aware of what would happen if there is a diagnosis, or at least getting people connected to the right resources is a huge situation to make sure that people really get that handoff in care. So I know we talk a lot about prevention, colonoscopies and the like, but understanding the treatment and outcomes just even at the basics or within your community, who are people who are educated about those treatment and how can help navigate patients is very critical. So the bottom line for patients is really keep active, healthy body weight, be aware of blood or bowel changes, know about your family history. If you're at normal risk, start screening at 50. The best screening one is the one that gets done well. And if you find a problem, don't wait. Early in treatment is important for a long life. So I want to just remind everybody too, and we'll talk a little bit this, and I think we've covered a lot of this as well, so I'm not going to go into great depth. But ultimately, we have to really think about how the information that we know about colorectal cancer, how do we message about ultimately linkages? How do we talk to people in our communities about what's going on with our populations? That map can be a really interesting thing to help motivate to get screened. talking to your team about how to do this, but we really think to also, in terms of our role as navigators, we can also think about access to care, barrier, and reductions. So ultimately, logistic and transportation concerns, having to have somebody with someone when they're going through the actual exam, those are the kind of things that we can help really think about. What are those resources? How can we help people plan and prep? And then really thinking about those coverage issues. Those are the things that we really have to completely consider, and also know, particularly in our safety net clinics, that we're really working with a lot of people who might have had really bad experiences with the health system before, or might only be used to sick care, but not even to preventive health care. So ultimately, we increase the access of people showing up. We know that if we go through all of these particular steps, from thinking about in-reach of who's eligible, to promoting information about CRC, educating about where the bowel is, what type of procedure, communicating with those patients and the healthcare team, helping reduce barriers such as transportation, interpreter translation services, understanding how they're going to access bowel preparation, thinking about time off work, those reminder calls, not just the day before the exam, but before they start prep. If something is found to be abnormal, helping with an adverse event like bleeding, or if a cancer is found, making sure that we have that handoff like I talked about, and making sure that we know clearly about what kind of insurance coverage for the screening and the prevention, but also for treatment. And then what I would also just encourage everyone is that if you're not part of a program formally, but you are doing this sort of work, capture that data. How many people are you seeing? How many are you outreaching? How many people are you navigating? What are your bowel prep? What are those adequacy for ultimately after having an exam? How many people apply and comply with a FIT and FOBT annually? How many people are using Stool DNA? This can be super helpful also for ultimately showing great outcomes and really supporting your role as navigator. So ultimately, the situation, I think, is that we've talked a little bit about that, is ultimately really thinking about what type of barriers do your patients face, who are you working with? We saw those increased incident rates for specific populations. We also know that there's a lot of fear, but this is something that you can absolutely do something about. The out-of-pocket cost can be something to consider. So really having a plan as you get ready to implement this sort of work, and at least as you message to people, is something that's critical. So one of the things I also just want to really remind folks and think about is that role clarification, is that who does what in your system. So one of the things I know is that, as I've been affectionately told from one of the senior leaders at an FQ, you've seen one FQ, you've seen one clinic, you've seen one community organization, you've seen one of them. And not everybody works the same. One of the things I think that can be very helpful in terms of thinking about your role in colorectal cancer screening navigation is understanding who's doing what. I know we have some folks on from Denver Health that a lot of times there can be the pharmacy involved formally, or I'm not quite sure at this point if they do, but previously there was a pharmacist involved who helped explain bowel preparation, would disperse that information and work hand in hand with the navigator to really think about next steps. Whereas the bowel preparation within one of the rural health clinics I work with is actually, there's a bowel preparation education class that's held monthly for everyone who's going in, and that's conducted by the navigator, and there's a script that's provided, and so people can come get the bowel prep shortly thereafter. So one of the things is just being really clear within your setting who is doing what around each one of these specific components. We know that a lot of times the navigator is the lead in terms of the contact with the patient, but in some situations we know that a nurse, a pharmacist, social worker, whoever it might be, enrollment specialist might do certain things, and then we jump in at a certain spot. So I think really just talking a little bit about, if you go back to the slide that I mentioned before, even just thinking about these core components about who's doing what, it really can make it clear about how to be most effective in making sure that your patients also don't have a lot of confusion. One of the things that I heard from a patient navigator, or excuse me, from a patient once is, it's great that I have the navigator, and this was written down in a review, is that I had the navigator, but by the time it was all over, I had 3 or 4 calls from the GI group and 3 or 4 times calls from the navigator. I think it would have been more effective if they both could have figured out who was going to call and remind me for what. So the other thing I just want to remind everybody is having those strong connections with your GI community about what they're doing, what you're doing, introducing yourself, thinking about following up so that if there have been no-shows, that you're thinking through with them about how to follow up on these sort of things. That can be a real critical thing to making sure that you keep a really good relationship moving ahead. So I'm not going to go through the review because we are going to be doing a post-test today, and I stole all of those from the slides that I'm getting ready to talk about right now. We have about 5 to 10 more minutes before we're actually at time for today. And I really want to say thank you for everyone who's joined. I think this is great that we have these 101 sessions. These are the kind of things, I think also some of the things that we're seeing in terms of the information, what can be confusing for folks, and the like, that will be critical for you to examine also as you think about your messages for those MI sessions coming forward. So I want to thank you for your time and remind everyone that the best test is the one that gets done and gets done well. Navigation is shown exceptionally effective. As a matter of fact, for preventive cancer screening, navigation in colorectal cancer is one of the areas where we are a bright spot, that we really show reduction in no-show rates and basically bowel preparation and ability to reach that cecum within the bowel, so seeing the entire bowel. We show that programs and folks who have navigators are typically showing very, very profound rates of show rates and good colonoscopy quality if there's a navigator. So thanks for all of the great work, and I will take any more thoughts or questions from folks, or we will go ahead and end for today. So we can open up the lines. I'm going to go ahead and stop sharing so we can open up any sort of lines that we need to. Let me just make sure you guys aren't going to see my horribly busy screen. And Taryn, anything that I've missed that we should cover today?
No, not that I can think of. Like I said, if you guys want to, you can unmute to ask questions if you have any.
I'm trying to figure out how to stop. And I know some of the CCSP team members are on, so I don't want to call on anybody, but here we go, stop share. Okay, any specific thoughts or questions? Lisa, Selena, Julie, anybody? Are we good to go? Okay, is there anything that I missed? Nope, good to go. No, we're all good to go. All right, awesome. And then I see Ashley's on from Denver Health too, good. And that reminds me, I think we said this at the beginning, that if you have anybody who's missed any of the former recordings who would like more information, we will be saving that on the PNTC site coming forward. So if we don't have any other thoughts, questions, concerns, I thought for sure, Laura, you would give me a heads up of anything I would miss. No? I think we're all good as far as I can see from the chat. You did great. Okay, well, good. I'm glad I didn't miss anything. So thank you all so much for joining. Really hope that you can join one of the advanced MI sessions coming forward. Again, that was provided, I think, in several of the Alliance links. It's also on the PNTC website. And even if you're not attending one of those, we're just really happy to have you guys engaged in thinking about the role of navigation in all things cancer prevention. A huge thanks to Taryn for all of her work and all the support of the PNTC. And on behalf of the Alliance, thank you guys so much for joining and have a great day.
Thanks, everybody. And like I said, this is recorded and we're going to put it up on our website if you would like to refer back to it.
All right, have a great day.